I am Valentin Fuster for JACC issue of January the 31st of 2017. The first original paper is entitled Protection Against Cerebral Embolism During Transcatheter Aortic Valve Replacement. The first co-authors of this paper are Dr. Samir Kapadia from the Cleveland Clinic and Dr. Sushil Kodali from the Columbia University Medical Center in New York. The last author is Dr. Axel Linke from the Leipzig Heart Institute in Germany. As an introduction, in TAVR, stroke remains a concerning complication and is associated with increased mortality and morbidity. Additionally, clinically silent brain infarctions seen on magnetic resonance imaging are associated with neurocognitive function changes and occur in as many as 80% of patients after TAVR. The majority of these so-called microinfarcts are due to embolization of debris during the procedure. The randomized trial that we are going to summarize, the largest of this type today, was designed to assess the safety of transcatheter cerebral embolic protection during TAVR and the efficacy in reducing the effects of cerebral embolization. The study included 363 patients with severe symptomatic aortic stenosis and planned TAVR who were at high risk for surgery, and they came from 17 centers in the United States and 2 centers in Germany. Just for the record, the so-called Sentinel transcatheter cerebral embolic protection device consists of 2 filters within a single 6 French delivery catheter percutaneously placed from the right radial artery or the brachial artery in a way that the filters are positioned in the brachiocephalic and the left common carotid artery before TAVR and are withdrawn into the catheter and removed after TAVR. The 363 patients were divided in 3 groups. The first group was a safety arm group of 123 patients. Of course, all underwent TAVR and the protective device, but the endpoint of MRI imaging of the brain was not done. Safety was the main issue. The second group of 121 patients were part of the device imaging arm. That is, they underwent TAVR, they had the protective device, and they had imaging with MRI of the brain. And the third group was the control group or the control arm of 119 patients who had TAVR, imaging of the brain, but they did not have the device. There were 5 questions to be answered, and we will try to answer one by one according to the results provided by the authors. Question number 1. What about the endpoint of measured adverse cardiac and cerebrovascular events, or MACE, including stroke? MACE and stroke at 30 days was not different between the different groups, although for the record, in the imaging device arm, at 30 days the incidence of a stroke was near 6%, while was 9% in the control arm without the device. But again, the results were not significant. We'll talk about the statistical power in a moment. What about the second question? Question about new lesion volume by MRI in the imaging device arm and in the control device arm was similar from a statistical point of view, although it was of 102 cubic millimeters in the device imaging arm and 178 cubic millimeters in the controls. Third question, about neurocognitive function, was similar in the control imaging group and in the device imaging group, but there was correlation between lesion volume and neurocognitive decline. Interesting. Question number 4. What about debris in the filters? They were found in 99% of patients, confirming the clear embolic risk during TAVR, with frequent embolization of non-thrombotic material. That is, the thrombotic material was minimal, there was some calcification in valve tissue, but most importantly, arterial wall tissue in 94% of the cases, perhaps corroborating the fact that more aggressive antithrombotic therapy would not have a significant preventive role. Final question, question number 5. The use of the Sentinel device was safe. Interesting results with trends in favor of the protective device, but not statistically significant. This fits with the title of the editorial comment, A Disconnect Between Logic and Data. The authors are Dr. Azim Latif and Dr. Matteo Pagnesi from Milan, Italy. This is their main point. Logically, a device that captures cerebral embolic material in 99% of cases should prevent ischemic injury of the brain. Yet, data from this trial does not appear to support routine cerebral protection with the Sentinel device. This leads to 5 interesting comments that may address this paradoxical issue. First and most importantly is the statistical power of the study that we just summarized. Drs. Latif and Pagnesi agree that the study was underpowered, and overall were trends in favor of the protective device. In fact, a meta-analysis of 3 randomized trials investigating the so-called Claret protective device favor the protective device approach in looking at lesion volume of the brain. A second point made is that the study had a lack of stratification for multiple TAVR devices requiring different techniques. The third point, also important, is that with the Sentinel device there was no complete cerebral protection, since the device protects only 9 out of 28 brain regions due to dual blood supply of the posterior circulation. They point out that if we believe that such protective devices are important, then we should not accept that there are areas of the brain that are unimportant. There is a fourth point. The MRI data was obtained at baseline at 2 to 7 days after TAVR, which was a critical endpoint, and at 30 days. They feel that the window of 2 to 7 days after TAVR is probably too broad and creates too much heterogeneity in the understanding of the data. And point number 5, it was interesting the relationship between lesion volume and neurocognitive decline, but there was no difference in cognitive decline between the 2 imaging groups. The problem here is that neurocognitive function done at 30 days may be too premature, and the patient still may be confused and with an emotional status that probably would be better if such approach of cognitive function was addressed at 60 to 90 days. In summary, this is a very important study, as we said, the largest of this type, but larger and more standardized studies are necessary to address the protective issue of such devices in patients undergoing TAVR. We just have a sense that with the right devices that protect the total circulation, which are under development, and indeed with larger and well-stratified studies, we have hopes that we might protect such patients undergoing TAVR, a procedure that is increasing geometrically day after day, and in which one of the main concerns, as we have pointed out in many audios before, is not only stroke, but cognitive dysfunction. Thank you.